evening. We would like to welcome you all to ASTRO's DEIinRO Social Education Series. I am Fumiko Chino, and I will be your host for this session on insurance disparities and access to cancer care. DEIinRO is a new social education series that focuses on diversity, equity, and belonging in radiation oncology, and it's brought to you by the newly formed ASTRO ex officio Council on Health, Equity, Diversity, and Inclusion, CHEDI, and the Division of Education. This series focuses on conversations with our members, residents, students, patient community, and you'll also hear from leaders in various specialties and industries on a number of topics related to DEI and belonging. The DEIinRO program is designed for us to share our experiences, research, and ask questions and formally discuss fundamental core concepts and structural issues within medicine and radiation oncology. Our hope isn't that it ends with just discussion, but that we can inspire change, and that you are encouraged to share your experiences with us and engage in the session. You're going to be able to do that by actually chatting in the fields below or by tweeting using the hashtag DEIinRO. I would like to take a moment for each panelist to introduce themselves before we begin, and we'll say our name, our institution, our research interests, and how long we've been doing this type of research. I'll start. Again, my name is Fumiko Chino. I'm coming from Memorial Sloan Kettering Cancer Center. My research interests are access and affordability, including financial toxicity. And I've been doing this research for approximately 7 years. So a fair bit of time, but really still kind of a baby in this. We can move on to Junzo. Please go ahead and introduce yourself.
Sure, thank you, Fumiko. So I'm Junzo Chino. I'm at Duke. My research interests are primarily with gynecologic malignancies. That's my primary clinical focus. But over the last really 7 to 10 years, have been getting more and more interested and involved with cost effectiveness research and other health services research and insurance and disparities research as well. So kind of from a side road.
Dr. Williams, do you want to introduce yourself next?
Hi, my name is Vonetta Williams. I am a graduating resident from the University of Washington. My research interests are gynecological cancer, specifically cervical cancer. I'm interested in clinical trial development and looking at translational research with respect to cervical cancer.
And then Dr. Barnes.
Thanks. Hi, everybody. My name's Justin Barnes. I'm a rising PGY2 at WashU. My research interests largely involve studying how health and social policy changes affect cancer outcomes. I've been doing this for a little over 4 years, so I'm really the baby of the bunch. Most of my stuff so far has been looking at Affordable Care Act and various components, how they affect access to care and outcomes.
Wonderful. I am so pleased to have you all on a panel today. And I will preface the beginning of our conversation with saying that we all did agree to go by our first names. However, we all are physicians. So it just clarifies the male Dr. Chino with the female Dr. Chino. So I'll start just by talking about the potential scope of the problem in terms of insurance and access to cancer care, in that I think we know that there are pretty huge disparities in terms of every step of the cancer cascade, from screening, diagnosis, treatment, survivorship, and end-of-life care. We know that there are disparities in terms of who is able to even walk in the door of some cancer centers, and that there are patients who are in rural areas that have huge access barriers to care, and that there are racial and ethnic disparities in terms of who is getting high quality care and who is able to afford their health care. I was going to ask Justin if he could maybe talk about why these disparities even matter when we're talking about access and insurance. What's the ultimate outcome for some of our patients?
Thanks, Fumiko. I kind of see that as two questions. Why does this matter in general, these disparities based on insurance status and other similar factors, as well as why do they matter right now? In general, when we talk about these disparities based on insurance, we're talking about how patients who are uninsured, oh, sorry, you got my 2-year-old joining the conversation. He's an expert as well. So when we talk about these disparities, we're talking about how patients who are uninsured are 2 times more likely to present with advanced stage disease than people with private insurance. Patients with Medicaid have similar rates. Patients with who are uninsured or underinsured are about 20% less likely to receive guideline recommended therapy. They're 2 to 3 times more likely to have consequences of financial toxicity, and unsurprisingly, with all these other things going on, more likely to die from cancer. The risk varies by cancer type, but we're talking for patients who are uninsured, anywhere from 20 to 70% more likely to die, or patients with Medicaid, 10 to 30% more likely. It's a huge deal. Now, why are we talking about this today? The Affordable Care Act now is ancient history. 7 years ago, that improved insurance access and improved some cancer outcomes slightly, right? We know that over the last few years, insurance coverage has been decreasing in the general population as well as in cancer survivors. Fumiko and Junzo a few months ago published a nice report in Lancet Oncology showing drops in cancer survivors. We've been doing a little bit more work expanding on that. Our best estimates right now is that over the last 4 years, over 160,000 cancer survivors have lost their insurance coverage. Who are these who are losing their insurance coverage? It's people who don't have good income, patients who live primarily in states that didn't expand Medicaid, racial ethnic minorities, precisely the people that need the insurance the most. And we're also starting to see some increasing consequences of financial problems. Now, some other specifics that kind of make this topic more relevant today. There have been a number of policy changes over the last several years that I think we should probably talk about. Just kind of briefly touching on these. The individual mandate, which was kind of started with the Affordable Care Act, requiring people to either enroll in insurance or pay a tax penalty, was removed effectively by eliminating that tax penalty. Back in 2019 was when it started. There's been the introduction of a bunch of loosely regulated health plans and short-term insurance policies that provide fewer covered benefits. These 2 things together are kind of siphoning off healthier enrollees from more comprehensive coverage plans, which is not only dangerous to them if some kind of catastrophic medical event like cancer were to happen, but with pulling some of the healthier pool from the more comprehensive plans, really it's going to be driving up costs for these people with chronic problems who really depend on these comprehensive insurance coverage plans. In addition to this, there have been changes with reimbursements to insurers, initially to kind of subsidize the insurers who are providing some subsidized insurance for low-income people. The government was paying like $7 billion back in 2017. These payments were terminated. Since that time, we've been seeing hikes in patients' premiums, which ultimately leads to more problems of financial toxicity. Our resident expert in that, Dr. Chino, both Dr. Chinos, can talk more about that later.
Yeah, I think one of the ironies of the Affordable Care Act is that with the erosion of some of the provisions, that it has become less affordable. The Affordable Care Act does not actually guarantee affordable care. And that's, I think, a real problem.
For sure. For sure.
Now, when we kind of talk about access and affordability issues, we often talk about, we use the phrase, the social determinants of health. And I think, in terms of a general catch-all phrase, it's increasingly being used. And I was hoping that Vonetta could talk a little bit about, how that actually discreetly affects access to cancer care.
Mm-hmm. Thank you, Dr. Chino, Fumiko. So all have it. So when we talk about the social determinants of health, I think first we can kind of define what that means. It is a term that's being used much more commonly these days. It's kind of in vogue. So social determinants of health are conditions, environments where people are born, live, learn, work, and play that affect a range of health, function, and quality of life outcomes. So when we talk about them, we think of a few domains such as economic stability, education access and quality, healthcare access and quality, neighborhood environment, and social and community context that people are in. And then when we talk about health inequities, I listened to the ASCO 21 talk by Dr. Rhea Boyd, and I liked her definition, that they are population level differences in health that are avoidable, unnecessary, unfair, and unjust, right? So these health inequity things are things that can be changed, things that we can work to improve. And a lot of them originate as a result of structural racism, which refers to differential access to goods, services, opportunities by race. And how do these things impact access? In many ways, as we can imagine. I want to speak specifically about clinical trials and, why does that even matter? Because you could say that when we run a clinical trial, we're not sure that there will be benefit, but the reality is, enrollment in clinical trials for patients who are uninsured or patients who live in areas where they can't easily access medical care, where issues like transportation can present a barrier. As we know, clinical trials also often require additional testing, visits, that kind of stuff that can be burdensome to patients. But enrollment in trials, just to look at two recent examples, for instance, with Herceptin, Gleevec, these are drugs that were obviously tested initially on clinical trial and produce great benefit to patients. So you're preventing access to potentially life-changing treatments. And studies have shown that for positive trials, there's a significant increase in person life years just from enrollment in those trials. So it is a significant issue. And the other thing that I want to end with is that it is something that we can fix if we dedicate resources to doing so.
Vonetta, are you concerned that maybe the results of clinical trials, which will then drive what we consider the standard of care, may be biased if we're only enrolling wealthy, non-Hispanic white patients, and how they may not be applicable to the general public who may receive care under that standard of care?
Yes, I think so, and this has been discussed a lot also, that the population in a clinical trial isn't very representative of the patients we see in clinic. For instance, cervical cancer. On clinical trial, we will optimize their hemoglobin levels. You'll optimize all sorts of different things. Their ability to, for instance, take chemotherapy, they have to have good kidney function. All of those kind of things are not our typical patients. So how well what we see on a clinical trial translates to the patients we see in clinic is kind of questionable. So that is one way in which it could impact things. Another way is if you have a homogeneous population, there may be, and I don't want to kind of conflate two different things, but there may be genetic differences in those populations that could in some way impact the results that you're getting. I know they use different chemotherapies, for instance, in an Asian population sometimes than they use here. And that could just be those population differences, whether it's really genetics or something else. But I think if you have a homogeneous group, it is difficult to say how applicable your results are to everyone else.
I think in terms of thinking about the general concern about insurance and access to care, ultimately, it matters because it directly affects our ability to provide high quality cancer care for our patients. So I guess my next question, and I'll aim this at Junzo, which is how does access actually directly affect the patients in our clinic? How is this actually interfering with your ability to provide the best care?
Yeah, I mean, I think that clearly anyone who's practiced for a significant amount of time is going to see this in their clinic. And in my clinic right now, I can think of multiple people whose care has been delayed because of issues with insurance coverage, needing pre-authorizations, not to necessarily beat that drum because that's a whole other issue. But I do think that it fundamentally stems from a lack of a comprehensive means of getting our population insured. I think the ACA was a step in the right direction, but it was just a step, and I think it was clear at the time that that's what it was. And even that small step, inspired multiple backsteps along the way. The repeal of the individual mandate, and the threat of a full repeal without any replacement in 2017, which came so close to being reality. I think the upside of it is that it stimulated us to marshal our forces and try to show that even the small, I don't want to say small because it's significant benefit from the ACA was beneficial in very concrete manners, to cancer diagnosis and survivorship, really. And that rolls down to all aspects of cancer care, and radiation isn't excluded from that. So I think we as a specialty have, I think the leadership's credit, Astro's leadership's credit, and a number, of thought leaders in this field have made it a priority to look at this seriously and to have a voice in this conversation. I think clearly it affects our patients. I sent something today to try and justify, a treatment for someone with medically inoperable uterine cancer. It happens across the board. So these are real issues that affect patients every day. I want to make a quick comment on Vonetta's comment about clinical trials. I was fortunate to be part of the SGO meeting this year, and SGO has similarly, it's Society of Gynecologic Oncology, similarly has really been a leader in putting these issues to the forefront, such that their plenary section 1 was focused on disparities research. It was sort of split between that and novel therapeutics. But to put that in such a primary place, I think shows a dedication to this research subject that I think, not that Astro doesn't do a good job and doesn't elevate to these projects, but I think that what they've done is also inspirational in SGO. But specifically to clinical trials, there was an abstract that was presented where we can solve this issue of racial disparities in enrolling into clinical trials if we make the efforts. I think it was from UAB, who literally created a navigator system for underrepresented minorities in their clinical trials. And with that, they brought their accrual rates up. And interestingly, and again, this is very relevant to what Vonetta said, the survival differences between races actually, in those that were enrolled on clinical trials, were essentially eliminated. So these issues are solvable. We just need to have the will and the perseverance to make it happen. I'll leave it
No,
at that.
I think that that is a really excellent segue to think about trying to frame this issue in the general context of research within health services research, which of course is this idea of we're not talking about a specific mechanism of action for chemotherapy or radiation, but health services research is really based on the idea of how do we provide the very best quality of care to the most people for the best outcomes at the lowest costs. So this idea of essentially the study of how healthcare is delivered and what the barriers are to high quality healthcare. And so I think it's a good time to actually to step back, because I think, Junzo, you had mentioned that, there's been this increasing priority in terms of looking at insurance and access over time. And I was wondering if you could kind of talk about when this health services research and access research really started picking up speed, because it honestly has not been that long.
Yeah, I thanks for the question. I think it is a I think there has been a recognition. So, I mean, we live in an academic world. We live in a world of p-values and randomized trials, and that has been set forward from day one as the pinnacle, like the randomized phase 3 trial, the level 3 evidence, level 1 evidence, sorry, that we build our practices on. And health services research does not fall in that kind of category. The biggest natural experiment in this, was the ACA, and actually was fundamentally due to the repeal of the mandate for states to all expand Medicaid, and that led to a natural experiment across the nation of some expanding and some not. That's the closest that we see to, sort of a natural experiment. So it's hard to frame this in the same language that we use for, the Outback trial in cervix cancer, just, from ASCO this year, where we have, clearly set out and balanced populations. These populations aren't balanced. It's by the design of the system, which has placed some people at higher priority for care than others. And I think the recognition of these, I don't want to say alternative means of research, because they're not. This is maybe more basic research than the constructs of a clinical trial. But I think it's really over the last decade, it really has picked up. And I think it's beginning to gain momentum. There was an abstract from, I guess, 2017 from Kurtelin Devil in Johns Hopkins, his group, who was looking at how health services research and disparities research in specific had increased in relevant to radiation oncology. And it had started to pick up, and he had seen trends going up since 2014 into the 2017s, and I think that's only increased since then. I think that would actually be a really interesting project to look at, to really quantify how has our specialty really reacted to this. I think there have been some high-profile pieces that have been published, but I think we need to really quantify this and make it a goal to make this really, as important as the other fundamental aspects of our practice. Radiation oncology, biology, and physics. It all happens also in society, and I think that's an equally, if not more important aspect that really defines care and outcomes for many, many people.
Are we seeing a journal name change where it'll be radiation oncology, biology, physics, and access?
That would be a bold step. That'd be a very bold step.
Because
I would say the leadership.
Our banner journal is so well acronymed now. Justin, I'll transition to you and ask you, how do we really improve our knowledge on health insurance and barriers to care? What are the steps in terms of what resources? How are we actually learning about how to do this?
So I'll speak from my own experience. A lot of it was just reading. There are some really nice resources providing some overviews. My personal favorite and go-to all the time is the Kaiser Family Foundation. They have a lot of nice reviews on, for example, access outcomes for people with Medicaid, lots of great information about healthcare reform topics. JAMA, New England Journal of Medicine, have recently had series on health insurance and policy. They tend to have more of a healthcare reform kind of spin on it, but I think it's extremely important and relevant as we are kind of turning the conversation from insurance-based disparities to how can we really achieve equity here. Other things I found helpful, there's a nice multi-group report that came out a couple months ago that talks about all the different insurance policies and insurance-like policies that are out there right now and kind of outlining the limitations they have. And I think another underutilized point of information that we probably should look to a little bit more are our own social workers in our clinics. They know everything that our patients go through and all the little loopholes that are involved with the insurance process. Maybe if we have another one of these panels, we should include one of them. They're more experts than I think any of we are on these issues. Well, those are just some things I found helpful.
No, 100%. It's funny. I'm sort of in the middle of working on this piece about emergency Medicaid. And I thought, you know what, the real way of getting the information about emergency Medicaid, meaning who qualifies and how fast it can be delivered, is to just ask a social worker, because they're the ones who are actually, you know, helping patients file for it. So I think you're correct. You're absolutely correct. Now, Junzo, you know, how is this research actually being done? So what have you seen, for example, as an editor at the Red Journal? What is coming in the door? What are the types of studies that are actually being published in insurance and access to care?
Yeah, I think that it's hard to quantify because it doesn't, you know, as we alluded to previously, it doesn't have its own niche, you know, as far as editorship, which I think could be another way forward. I think that actually the leadership at the Red Journal has really done leaps and bounds to make this more accessible, more, you know, published, give the, you know, readership access to these kinds of studies. But they really run the gamut. You know, I think that the sources of research really come from national databases. They come from registries. They come from individual clinics and their experiences. And it's a bit similar to education research, which is another sort of, you know, interest of mine. It's hard to do a randomized trial in education, you know. You kind of have things and you try to describe it as best as you can, but you need editors and reviewers who are able to understand that the bar is, it's to say it's higher or lower is wrong. The bar is just different, you know. I think there can be high quality research in this space. There could be low quality research in this space. And we need to be able to recognize, you know, what outside of the classic, you know, paper, you know, is valid. One of the things that is very hard to get traction on sometimes are narrative sorts of like qualitative interview projects. I think it's hard, you know. You can't get too specific about anything, but some reviewers like look at these and
Looks like we lost Junzo there for a minute, so I'll let his connection reset. And I'll pivot over to Justin again to talk specifically about what actual databases are available for evaluating things like access, which is kind of fungible. There's certainly, I think, more established databases for evaluating insurance.
Yeah, so thanks, Fumiko. Just like any research question, the best choice of data to use is going to depend on the research question. I can't see the people we have here joining with us, but I imagine most of us are kind of in the oncology fields, and most of us have probably heard of SEER and NCDB, a couple of the bigger projects. So SEER is the Surveillance, Epidemiology, and End Results Program. Now includes up to 16 states, their registries, and provides a bunch of information regarding some demographics. Unfortunately, socioeconomic variables are limited to kind of county level income, education, and things like that. So it's really hard to get granular level data with them. Unfortunately, they don't have lots of treatment information, which kind of precludes some analysis with just the regular SEER. That's kind of overcome a little bit with some of their joint projects like SEER Medicare. But again, SEER Medicare is by definition limited to people with Medicare. So a little less helpful when we're trying to talk about other types of insurance policies. The National Cancer Database is massive, whereas SEER is population-based, kind of just on kind of how it's sampled, if we can call it that. NCDB just includes the Commission on Cancer Registries, and there are a lot of those. And they get a little bit more granular socioeconomic things by zip code level. But again, we're still lacking that individual level stuff. Other big registries out there that I've seen used sometimes, there's a combination of SEER and NPCR, the National Program of Cancer Registries, that includes incidence rates. They don't include specific insurance things because this is kind of county level or some geographic based incidence rate. But these things are nice when looking at policies, which is what I'm interested in. Kind of the analog to this data set for mortality rate data is through the National Center for Health Statistics. You can get through that through the CDC website, like CDC Wonder, or even through SEER's program. If we're interested in cancer survivors, there are some really nice survey type things that cover the entire nation. The Behavioral Risk Factor Surveillance Study, BRFSS, the National Health Interview Study, NHIS, and then looking at specifically expenditures and how much patients are actually paying, the Medical Expenditure Panel Survey. These are all honestly pretty similar in terms of the kind of questions that are asked. I have to go into the actual documentation to remind myself the nuances between them, but I've seen a number of projects with those. There are other kind of more novel databases that I think are potentially promising that I haven't seen used as much. One of these is the Flatiron database. There was an ASCO plenary using this data to look at time to treatment with regards to Medicaid expansion. There are some institutions that have access to this. I know Yale is one of those. If you have access to this, use it. I think it's a neat resource. Similarly, there are some all payer claims databases. I haven't seen these used as much, but essentially they report all the claims from every type of insurance possible, and can be a neat resource. These are kind of the main databases that are available for people to tap into. I think we're starting to see more of single institution type studies piloting interventions, which I think is a really neat direction when we're talking about how do we start fixing some of the problems.
Absolutely. And I think that, we have large numbers with the databases, but sometimes they don't get that granular information about what was the true barrier for access to care, if it was, the cost of parking, or if it was the lack of childcare. Moving forward, I wanted to ask Vonetta, because I know you've been interested in designing clinical trials to think about how do we actually improve access to things like clinical trials, designing a clinical trial to improve access to clinical trials. When you started moving into this space of the how care is delivered and how to potentially ameliorate some disparities, how did you find mentors? How were you able to actually identify people who could help you start moving forward with this research?
Thank you, Fumiko. So I think you're asking two questions I think I heard. Mentorship in terms of finding people who can help you conduct this type of research and design it. And then what are some of the things we can do to improve access? So I think I'll take the second one first. I think most if you're applying for, let's say, NIH funding for clinical trials, you do have to make some statement about, trying to enroll a diverse population. So most, I think, do that, but then I think apart from just asking how people will seek out a more diverse population, making them accountable, because you've received public funding for this. So I think you also should have to answer at the back end, not just say you will do something, but then make them accountable for actually accomplishing that, right? And then one of the things that I think people are looking more at is enrollment criteria and how narrow they are. Now they're narrow for various reasons, but how can you make it so that it's more inclusive, so that more patients can enroll, and patients who typically, one of the things that was talked about a lot was, for instance, GFR, and how it had excluded certain patients from being able to participate. So those are some of the things that we can look at, making sure that people are accountable for actually not just saying that they will enroll a diverse patient population, but actually enrolling them, and then looking at enrollment criteria and how that could impact diversity of your patient population. Then in terms of mentorship, for myself, we just went through COVID. So I would say I've used many resources, kind of like looking for a job. You do some cold calling of people, emailed numerous people who I saw were experts in the field that I wanted to be involved in. And use of social media also has been, pretty useful. So those are some of the techniques that I have personally used to find mentors in that sphere.
So you're saying that we can't all be lucky enough to be born into a family where we have radiation oncology mentors within our own family? That's so weird.
Sadly, no. I do know some families like that, but no.
Gotcha. Okay. Moving forward and trying to kind of tie in some of the questions that have been coming in terms of, once we've identified disparities in insurance, in survival, in access, how did we go about then, showing that what we've done needs to be fixed, and then essentially implementing it? What are the potential interventions that we can do in terms of fixing access and disparity issues? And I think, kind of coming from the top, we've talked a lot about the Affordable Care Act. And one of the things I always try to encourage for people is just that, we need to advocate for our patients, for our field, and for our national healthcare policies that really serve our patients. So I would be remiss to essentially say not plug for something like, for example, Astro Advocacy Day, where we really do put our faces in front of the important people in the world and talk about why this type of research matters and why the high quality delivery of radiation oncology really does matter. But in terms of, what are the national efforts in order to improve access to care? I'll toss this to Junzo, now that you're back.
Yeah, I apologize. So, I think that, you've brought up Astro and ASCO and a number of other organizations such as SGO. And I think that we as an institution need to take this ownership. The federal level, I think, can do some things, but we do have a fractured system. And trying to do this piecemeal, I think, can help. And I think, definitely, we work from the ground up as well as from the top down. But I do think that using the national levers that we have are going to be the most important things that we could personally do, as well as advocating, to our federal and state level, representatives. It is difficult, though, because it is here and there. It's the social worker's dilemma of trying to piece together travel for a patient who lives too far away for brachytherapy, and then getting them emergency Medicaid, as we talked about earlier, getting them housing and getting them gas cards. Getting them a place like somewhere for their kids to be. I'm just talking about one patient I saw. This is a single patient in my clinic. I think that these efforts, I think, can help tremendously. And the American Cancer Society does the same thing, and we can stitch together support for our patients out of these disparate efforts. I think, but we also need to work from top down. Right now it is very much a stitching of a patchwork, and I think if we can advocate for more blanket to stretch the analogy approach from the top down is really going to be very helpful. I mean, they'll still no public policy is perfect, but I think we can do better really from both ends.
Yeah, I think it's really interesting because President Biden, as you know, has the Cancer Moonshot campaign with the idea of finding the next cure for cancer through enhanced research funding. And it's a tragedy because I feel like we could cure cancers all the time, but we're not because of access and insurance issues. So we don't even really need the moonshot. We don't need to be in the stratosphere. We need to be on the ground with, people who are just struggling to afford their care. I'll pivot to Vonetta and ask, what funding mechanisms have you seen, also drawing from some of the questions, which is, how do we get more involved in this research and what funding is available for us to actually pursue it?
I think particularly now, within the last year or so, there are lots of funding opportunities, particularly focused in health disparities, etc. I mean, the NIH does have funding. There's Corey grants, kind of patient-centered grants, NCI, all of these, and then there's lots of industry and private funding also. So there's multiple funding opportunities. One of the things that had recently been discussed is the disparity even in who gets funding to do this kind of research. So that's something we need to be mindful of also. And one of the questions I'm seeing in the chat is concerning types of trials for interventions to kind of to address some of these access issues. And there are several trials, there's patient navigators. There were plenary sessions at ASCO that developed various trials that people have to try to enroll Black men. I think it was Dr. Ford, Dr. Marvella Ford, I believe it was, has a trial looking at just increasing participation of Black male patients with respect to lung cancer. So there's lots of trials that are looking at improving these access issues that are currently underway right now. So lots of funding available. We just have to actually apply and create those trials to address those issues.
I'll pull a question from the comments, which is also one of the questions I had now, which is when we think about solutions, again, we've mentioned the Affordable Care Act many times, and Medicaid expansion was one of the main provisions. And I'll toss this question to Justin. There are problems with Medicaid. I think, it is not, there are clear disparities in care delivered for patients with Medicaid. And I was hoping that you could speak to that a little bit in terms of, is it the end-all solution? Should we just give everyone Medicaid? Is that going to be it?
I love this question. Thank you for giving it to me, Fumiko. Kind of backing up, the question in the comments kind of touches on why would we give Medicaid to people if it can potentially exacerbate some of these disparities? And I think that's an excellent question. What I think we need to remember here is first, kind of backing up to some of the stats where Medicaid is associated with overall just worse survival for cancer patients, and is this surprising given the lower rates of providers accepting Medicaid patients? There's a nice ASCO abstract just last week that actually outlined some actual rates where I thought that was really interesting. But I think we need to remember here, is this a causation or is this a correlation type of problem? When we think about the people who are on Medicaid, by definition, these are people with lower incomes. can we say that it's the Medicaid that's causing these poor outcomes, or is it kind of all of the conditions that led them to qualify for Medicaid that are causing these disparate outcomes? And I don't know the answer to that question. With some of the data that's coming out with Medicaid expansion showing improvements in stage 8 diagnosis, which maybe is suggesting that people are getting into their physicians a little bit earlier. And now we have some early data showing that survival is increasing. I hesitate to say that Medicaid is going to cause worse outcomes. I think for these low-income patients, it's actually helpful. Definitely better than the alternative. But is it better than what we have now? I don't know. Medicaid is still run by these private insurance agencies, which are fraught with problems. So is this Medicaid for all, Medicare for all, is this the solution to all our problems? I don't know. We might be better off taking things a step at a time and seeing what works and adjusting as needed, but I don't know. Great question.
I think the comment about Medicare for all, I mean, so Medicaid, is it evidence that the government cannot provide good healthcare or good reimbursement? I think Medicare is the counterexample. We don't say people with Medicare, we don't see negative consequences of Medicare, and I think that very much can be. I mean, we can. I don't want to sound like a politician here, but we can do this. It's possible. It's just we need to look at it as we're caring for our populace, not that we are trying to, give people something, because they're falling behind. We need to actually care for everyone. And what can we do to make that better? We can pressure, if we're in practices that Medicaid is not, is discouraged or whatever else, we can push back against that. That's something that we can try to do as a group and as individuals, and really fight for people who, people who don't have insurance, and fight for them to be, approved for, for care anyway, do MD overrides or wherever it's termed in your institutions. I think, we can make a difference. And, there's nothing, we can do this correctly. And I think that the examples are literally right in front of us.
Yeah, I think that one thing I wanted to highlight is that based on my own research on financial toxicity and out-of-pocket costs, that those patients who have public insurance, either Medicare or Medicaid, actually have some of the lowest out-of-pocket costs. Now, patients with Medicaid have really high financial toxicity levels, but it's because even a $2 copay can be too much, or even the cost of the bus or the metro to get to the facility to receive their care can be insurmountable. But it's actually, I'll be honest, fairly affordable care. It just determines who accepts it, like you said. And I think one of the major wins of advocacy from ASCO was actually when the clinical trials were covered under Medicaid. So that just happened, I think, earlier this year. The idea that clinical trials, standard of care treatment under a clinical trial was not covered for Medicaid, and that has now been changed. And I think that was directly as a result from advocacy at the national level. I'll pull a question from the comments, because I do think this is really interesting, and I'll open it up to anyone, which is, how can we learn from the VA healthcare system in terms of actual delivery of equitable healthcare? Because I do think of them as being a model within the United States of how care can be both efficient and inefficient, depending on how you feel about the VA healthcare system. Does anyone want to take that?
Yeah, I mean, I think the VA it's an excellent resource. I mean, there's reasons why people maintain it and and go to it, even if they have Medicare or other insurances. But I think it's variable in its implementation, and it gets I mean, unfortunately, the lay press does tend to focus on some of the missteps, of it, because we do want to treat our veterans well. We do want them to excel, and when we see, and rightly so. I mean, we should point out the failings of these systems. That's an important part of it. But I do think that it is very possible to give excellent care in the VA health system. I think certainly at Duke we staff a lot of the VA systems, and I think it's an excellent service. But it like anything, it's dependent on the situation. It's dependent on multiple other factors at each given site.
What I've noticed about the VA is that the capacity for coordination of healthcare is incredibly high because, again, it's a closed system. And that itself, for example, the homelessness program, if you want to talk about how do we get to the bottom of the social determinants of health and think about potential interventions or solutions, homelessness is a huge problem. And that will be the root cause of many, many compliance issues. And if you actually can help, veterans receive mental health services and actually, have stable housing, you can do a lot to ameliorate some potential downstream healthcare effects. I will pull another question from the comments, which is, for this one is for Justin. Can you give some examples of any intervention trials or how to actually potentially improve access in terms of, for example, things that you know from the literature or from your own experience, what the things that actually can help?
Yeah, for sure. So this is kind of moving off of the insurance thing. I don't know that we have any special interventions outside of a policy level from an insurance standpoint. But things I've seen at Astro last year, there was an interesting study looking at essentially setting up Ubers for people who have trouble getting transportation. I think that was a really, really neat initiative. I think you could think of similar things. Fumiko, you were talking about childcare type things. Could we talk about trying to subsidize that or help people organize that? From other standpoints, can we coordinate getting screenings for people? This would be less of a maybe institutional type thing, but New York City and Delaware have implemented these interesting colorectal cancer screening programs where they essentially pay for uninsured people to get their colonoscopies, and in some cases they'll pay for treatment if cancer is diagnosed. Can we think about doing that in other places? These are a couple of the things I've seen, and the possibilities are endless. I think these take on more of a kind of quality improvement type flavor versus a traditional intervention. But there are lots of opportunities ranging from EMR type interventions to kind of cue us in on when we should be taking a closer look at things, to actually getting down into the communities and talking about ways we can help people who struggle.
Vonetta, I'll ask you a question, which is, I know that you had spoken specifically about, for example, the role of navigators and, for example, the idea of engaging communities in supporting patients through cancer care. And I was wondering if you had any additional thoughts in terms of potential interventions to improve access to care within the community.
Yeah, there's a lot of, thank you for that question, Fumiko. I just wanted to go back to the VA briefly in terms of coordination of care, because there are a few good points raised in the chat too. The VA is unique, and the coordination of care, I think it needs to be talked about some more, because it's not just for medical providers. It's every other supportive system, social work. You can get homeless veterans can stay in housing at the VA during treatments. There's so much support they can get, smoking cessation. They even have at our VA, they have support classes. They can talk to other veterans with cancer. So all of that within the VA system, I think, really works together to improve outcomes for veterans. Often at least my experience is that I've had veterans who are not married, so they really don't have a very good support system. So one of the concerns is sending them outside for care, because then they don't have all of the other support system that the VA affords them to coordinate their care, just getting rides, people to call them, to come in, all of those things. I think, apart from the excellent care that they're getting, radiation, medical oncology wise, all of those things really matter to getting them through treatment. So I just wanted to talk about that with respect to the VA. And then I think you asked me about different things that we can do in lines with Patient Navigator. So one of the things, even in that they're trying this new Biden administration, there was some talk about going into, for instance, for Black communities, going into barbershops. Different communities, and I'm sure it's different. We all kind of interact in our community differently. So one of the things is that Black barbershops are kind of like churches too, in kind of Black communities, are places where you come to get together with the rest of the community. People trust their barbers, and by using these community establishments, kind of organizations, you get more credibility with a community, and they're more open to any intervention you offer. So, and those things probably are not that costly to do, but it's a way to reach your patient. When we talk about screening, all that kind of stuff, we can use some of these community organizations to improve that for our patients, in addition to patient navigators, that are kind of essential for making sure patients make it to their appointments, etc. Even know about their appointments.
Yeah, it struck me during the initial rollout of the COVID vaccine, when they were setting up these mega centers at arenas, how that was gonna be a failure to certain communities who would never go to a football stadium to receive their vaccination. And I remember thinking, this doesn't need to be in an arena. It needs to be at a church. It needs to be at a dollar store. It needs to be at something within the community if we actually want the hardest hit, hardest to reach communities to actually have access to this vaccine. And that's why I was so pleased when, for example, MSK opened up a vaccine clinic in a church in Harlem, because I thought, okay, this is how we actually deliver healthcare within the community. We are 4 minutes from the end, and so I wanted to start wrapping up. And I was hoping if I could get each one of you to talk about essentially how. I think there are large databases, there are national healthcare initiatives, there are advocacy efforts, but ultimately, again, we need to help the patients that we see in clinic tomorrow, who are in front of us, who have a need, who have an access concern. And I'll start with Junzo. How do you actually help the patients that are literally in front of you struggling? I know you talked about, your patient who is having, for example, problems with childcare. What are the concrete things that we can actually do to help access?
Yeah, and again, as we said through all of this, I think social work does an amazing, like the amount of resources that they can bring to bear is incredible, and that's, I think, from a marshaling of resources is key. I think, though, we need to look at ourselves and see, and I think we all do, and be empathetic, fundamentally. I think, the vast majority of people get into medicine to help people, and I think things have gotten a lot better for this, but we really need to look, at ourselves and say how, and really empathize with our patients, and I think it seems like little sometimes, and it is, it is little, but sometimes just the comment of how can we help, and listening to someone, as opposed to just, sort of, you know, referring everything or sort of saying, well, this is my job, this is what I'm going to do. I think being empathetic, I think, can make such a difference, and can give people something to hold on to, you know. I mean, the world, as I'm sure we've all been through recently, can seem like you're tossed amongst the waves, and just having some empathy and you know, working on someone on a human-to-human basis, we can't forget that, and I think that helps so many people, including ourselves. You know, I learn and I learn from those experiences just as much now.
We are rapidly running out of time, but any other addition? Yeah, Junzo, you went on for too long. Or Justin, any other additional thoughts in terms of actually how to help the patient in clinic, other than, again, I agree, active engagement in terms of actually identifying the problems and then trying to fix them?
One small thing that I've actually realized is just sometimes listening to my patient and asking a question. Oftentimes I'll get a patient and I've been told they don't want this. So then I go in and I ask, well, why don't you want this? And it is not infrequent that it's because of some misconception. Well, somebody told me this, or I think this, or I don't want to go on that trial because they make you do that, right? So all of these little things, and so now it's kind of my practice to ask, well, why did you come to that decision that is seemingly not in your best interest, right? And oftentimes it's just because of a misconception. They think they heard something, or they got some miscommunication. And once we've discussed it, they actually change their mind. So I would say just kind of listening, and not going with the, oftentimes we see in our patient charts, patient is non-compliant, patient is not interested, all of that. And when you take the time to listen to them, that is not actually true.
Any last thoughts from you, Justin?
Nothing really new beyond what Junzo and Vonetta have already said. Just what comes to my mind is taking time and being patient and trying to understand where our patients are coming from. A buddy of mine just recently told me about a patient who showed up late to his clinic, and he was frustrated, of course, because things need to roll on time. But when he found out the reason for her being late, that she didn't have a ride, the buses weren't running, and she walked several miles for over an hour just to come to his appointment. He broke down in tears. And I think it's important that we keep in mind the struggles that our patients face. And like Junzo said, be empathetic, try to understand. Like Vonetta said, ask why, what are the reasons? I think we can do a lot of good once we really start to understand one another.
On that note, I would like to thank all of our panelists, and I would like to thank you for attending this session. Our next session will be a Black Men's Health Town Hall, and it will be held on Tuesday, June the 22nd from 6 to 7 p.m. Eastern Time. Just like this session, no registration is required, and you can find more information on upcoming sessions at astro.org /DEIinRO. This year will be a critical year to ensure that we have impact in the development of more of sessions like this. So please ensure that you are a member of ASTRO in good standing, as we do need you to vote this fall to ensure that the ex officio Council for Health, Equity, Diversity, and Inclusion is voted in to the bylaws revisions to be a fully formed voting member of the ASTRO board. So please check your membership, be sure to vote, and encourage all other members to actually vote for HEDI as a council. And on that note, I again thank you for your time, thank you for the panelists, and I will see you at the next session.